Have you been able to recognize those and help with that? You do a postpartum depression screening as one of your assignments. It's just a pass-fail, but it's something that's really helpful to do and to kind of determine whether or not somebody's at risk for something like that. We'll go over a little bit of that and why we do that in both in the hospital setting and in the clinic setting, in the pediatric environment and in GYN environments. So when you look at this picture, you're going to say to yourself, well, yeah, this is what we all expect, right? For that picture on the left, everybody's happy, they love their babies, they're so excited, they just had a birth, right? I mean, that's what most people assume in some regards that happens when you have a baby. But actually, that's not always the case, right? Sometimes people get pregnant, and that's not something they intended to have. And then maybe even they got pregnant, were so excited to have their baby, and they're so excited to, after the delivery, and then all of a sudden they start to feel depressed, and they can't understand why they've got this beautiful baby, and their situation is okay, okay in terms of, I should be happy, why am I not? And so there's a lot of guilt associated with this, and that's what we're going to start talking about today. Think about incidence of depression. You think about the non-pregnant patient who comes in, might have about 8 to 10% risk, okay? But overall, maybe up to a 20% risk. Now, some of you might say, well, that just doesn't seem reasonable. I hear more and more people say that they're depressed, okay? Well, interestingly, I want to talk about situational depression here and actuals when we have some sort of chemical depression. Situational depression, like loss of a job, loss of a loved one, loss of a marriage, something that's big in your life is different. Okay, a situational depression is something that will pass. It'll take some time, but you're not going to be lifelong depressed. It's not something that's a chemical imbalance. That's different. Okay, when I, as a practitioner, would get people talking to me, I think I'm depressed, I think I have these, and they have these symptoms, it is often kind of comforting to know that this, over time, which is the best healer, is going to heal this, but it'll take a lot of time to get through the grief process. And when you're going through the grief process, you are depressed, okay? Been through a lot of hard situations in my life, and there were times where it was hard to get up and hard to do what I needed to do, but I moved through that, and it sometimes feels like you're moving through that mud, right? But then it gets better, and it gets better slowly. That's not what we're talking about today, per se. We're talking about people as well that have something that might need medication and a lifetime support in terms of counseling and that, okay? So that's something that we have to determine when people are pregnant, okay? Now, the more complicating thing is that people that have depression that go into pregnancy, sometimes it gets way better when they're pregnant. They feel great. They go off their meds and they feel awesome. And some people, that is not the case. It gets worse. So as providers and as nurses, we have to determine what's best for them. And a lot of women will come and say to me, birthing people will say, I don't want to take medication. I feel worried about taking medication while I'm pregnant. What do you think I should do? So there's a couple things we'll talk through today on how do we help them determine whether or not medication is something that they should be doing or not be doing, and how do we determine, the leeway in that. How long do you wait? Okay. All right, so the numbers are pretty similar when you're non-pregnant, pregnant, and postpartum in terms of how often it happens and might be for long term. So those numbers are just good for you to see how to put those numbers together. The key here is how many people really express maybe the baby blues versus those who are actually depressed and then go into what's called a psychotic event or psychosis. Look at how high it is for those people to have postpartum blues. I had it each time, okay? And it actually got a little worse with each one. I was almost anticipating it, but then really I felt kind of weird when it would happen. Ben at that time would always share with me, that's normal for you. That crying, that feeling like, oh my gosh, I'm overwhelmed. I remember crying at different commercials, different happy things that would happen. And that lasted almost a good 2 weeks where it was just I didn't feel myself. Can anybody tell me why that might be in those first 2 weeks after you give birth? What's present still in your body that would cause this high range of emotions and possibly even sadness? Who can tell me? In Rochester? What? Who would think?
Hormones.
Yeah, hormones. Right, you've had this placenta circulating all these awesome hormones, the feel-good hormones, all of it, right? You got this baby on board, and then the placenta leaves. Do you think, and the hormones don't leave right there. It takes a long time to reabsorb, and you have 50% extra blood volume that at that time is being absorbed and excreted over a period of time. And it takes a few weeks for that to happen. So the excessive amount of hormones that are not going to a baby any longer are going to your system. Your adrenals are taxed, your hypothalamus is taxed, and so the metabolic rate of this, because everything's pretty slow, as you then switch not only from a pregnant state, but to a lactating state. So remember, in the presence of lactation, oxytocin is still there, that's the feel-good love hormone, that's still present, but prolactin is there at a high level. And prolactin, in the presence of prolactin, you don't have estrogen. And so for a lot of us who experience our menstrual cycle monthly, feel a little out of whack that first week prior, that last week prior to our cycle. Why is that? Because estrogen is on a huge decline. And estrogen is what makes us feel good, okay? Estrogen is what's present at the highest amount at ovulation. When estrogen is at the highest, progesterone is lower. It's an x-axis. When estrogen peaks is when all of a sudden progesterone kicks in, and so for the last 2 weeks of your cycle, that's going higher. Estrogen's going down. At the lowest of estrogen and the peak of progesterone, that's when your cycle happens, the shedding of the lining of the uterus when you're not pregnant. Most people express some sadness or feelings that they feel different a few days before they get their cycle. Anybody care to lift their hands at that? I'll lift mine. All right. Most of you, were like, what is wrong with me? I'm irritable. I have no patience. I want to literally jump out of my own skin, and then all of a sudden your cycle comes, and you're like, I don't know what was wrong with me a few days ago. Okay. Now that's when most fights happen, and you get all worked up about different things. Well, this is exactly what's happening right after you give birth for a couple weeks. But guess what? You got lack of sleep. You're supposed to be happy. Everybody's looking at you like, why aren't you? Okay? So that's the thing that goes and has somewhat of just a mixed message for people. So as long as we can say to them, this is normal. So when I used to work with couples and talk with them after they give birth, I would just let them know that this next 2 weeks, there's a lot of support that's needed. And it'll go away. And when it doesn't go away is when I am concerned. Okay? So when you think about that and all those numbers there, let's talk about what's too long for these things to be experienced. All right? So before that, what we have to do is listen to women. Now, I know my first, the 3 to 4 days before my cycle, up to about a week, it's probably best for me to talk through things, but we tend to sort of knot and hold that in, and then something happens and we blow, okay? Well, it's the same case here. We need to listen to people. We need to make sure they're heard. Look for their behavioral changes, okay? And look what's normal versus abnormal. That's what our whole goal is here in training you all in this area, is what's normal versus abnormal. Pregnancy itself is an upheaval, but then you give birth and it's even further. So most people are pretty concerned about how the labor is going to go, but they're not quite sure what it's going to be like afterwards. So they don't spend a lot of time on diapering, on breastfeeding, and all that kind of thing. They're more worried about labor. So when everything happens and that first 24 hours goes by, all of a sudden you think, oh my goodness, I'm overwhelmed by these feelings. They're usually pretty good. I'm pretty protective of my fetus. I can't believe how much love I have for that baby. There's a lot of self-esteem that's increased with your laboring process, and then you become more self-absorbed as well. So all of this kind of leads to a couple different things. We'll talk about that. When you think about depression itself, the etiology is pretty much unclear for sure, but we know that hormones play a big part in it. Okay. The biggest case here is neuroendocrine changes, right? You go from a couple different states, and it's a complete switch in how the hormones work within about 24 hours of the placenta being removed. Okay? So from that, you're expected to stay up, be awake, feed your baby on time, feed yourself, and adapt to something that most people, when it's their first baby, it's a pretty hard adaptation. Going from completely independent living to being somebody's dependent on you. Okay? So when I talk about things that are normal, and when I saw GYN patients, I took care of teenagers, there is a level of normalcy, right? This is normal for you to experience. There's a range of this. If it gets outside, those types of words are very, very helpful. I'm not trying to take away from anything that they're experiencing, but sometimes it's good to hear that other people are going through this. Now, there are cohorts of people that go through what's called centering pregnancy, and they get together right away after the birth as well. They start talking in groups about what is it that you're experiencing, and because everybody's experiencing it, then it becomes something that feels normal. And I don't know about you, but when I know that other people are experiencing something very similar to me, then it alleviates the stress and how big it is in my life. So talking about it's huge. The other thing is that sometimes birthing people decide to eat too much, and so their weight change is quite big. So when they get done and they stand on the scale about 4 to 5 days later, they're pretty shocked that they've only lost about 12 pounds. Okay. And that's pretty normal because the birth of the baby is about 7 to 9 pounds. In Minnesota, we grow them big, about 8 pounds 6 ounces. And so we have our normal average is greater than the national average. National average is 7 pounds 6 ounces, but in Minnesota we're a little bit higher. And then you have the weight of the placenta, and then you have a little bit of the fluid. So when you've eaten for 2 and you've gained 50 pounds, that's a big change when you're thinking that this is all going to go away. And then the hard work starts. So they can be a little overwhelmed by their weight as well. And I educate people before that as well, especially in their second and third pregnancies, to stay within that 25 to 30 pound weight gain. All right, who's at risk for this? Well, African Americans and Hispanics have an increased risk. If you're single, you have marital instability, maybe some poor social support, not a great social system around you. Some big adverse life event that's happened, maybe the loss of a loved one prior to the birth of that baby. Maybe if it's unplanned too. Even though you're really, you have the means to take care of this baby and you're in a good relationship, but the unplannedness of this baby and timing of it might be too close, or you just weren't ready for that. Okay. Some people are actually pretty ambivalent towards pregnancy. I didn't really know if I wanted to become a parent or not. Here I am presented with this, and so they kind of go into pregnancy not knowing what to do, and then the birth of the baby happens, and so this can be a contributor as well. All right, and then low socioeconomic status can also be one. We can't forget a personal history of depression, and why is that? Why would that be something we'd have to watch for? It's something I ask with every visit that I have when you're a new OB or you're a new GYN patient. Why would that play a part? What do you think?
I mean, your hormones are getting all messed up again, so if you already have a history of it, it's likely it'll spike.
Yeah, and how about even just if your mom explained? Now, I'll hear a lot of people who say, my mom had postpartum, and so I'm not shocked that I do. Well, there are some cases where the hormones of your parent is similar to what you have. It's not always the case, but we'd be watching for it, okay? Now, the case where somebody wakes up and thinks, oh my gosh, I finally come out of this, okay? I've kind of gotten out of this. I'm 2 weeks out, 3 weeks out. They might feel that they've been robbed of sort of that joy of their baby. Now, the first person that actually talked about this is Brooke Shields. I don't know if she's one of the few people that started this about 10, 12 years ago, where she started talking about postpartum depression and what it felt like to feel like you wanted to actually leave your baby and like literally walk out of the room and never come back, or drop your baby off somewhere and never come back, where she could not believe that she actually had these feelings and she felt so guilty about them. And that whole process is something that a lot of people that are pregnant that don't even want to talk about that. I can't even believe I say this. And then when it gets to a psychosis event where they actually feel like they want to hurt their babies, there are some great documentaries about that, where there are people that have talked about this, where they would go to their partners and say, I have this feeling that I want to hurt my baby. You need to take this baby away from me. This is what I've been thinking about. and they're just distraught about it, hurting them, taking a knife, all sorts of things. Okay? And when that starts happening, we absolutely need to intervene. Okay? Absolutely need to intervene. Things that we have to watch for. Poor sleeping. Of course, it's a new baby, so we want to watch that closely, whether or not it's just from that or they just can't stay asleep or get to sleep. They have a decrease in appetite. Okay? They might maybe want to self-medicate with alcohol, and that's new for them. I have one other. And they had a history. Sometimes if you have a history of someone not wanting to come to their prenatal care visits, maybe that was something that before that, but they couldn't articulate it, and now we see that they are actually depressed, and they can hopefully now articulate that. The good news is that when a mom comes in at her postpartum visit at 6 weeks, or when she starts coming in to bring her baby within that first 2 weeks, we do a screening, both in the pediatric office and at her well woman exam as well. So she'll get followed up on both ends. Do you feel depressed, and kind of do the postpartum depression scale. Okay, so we'll figure that out pretty soon after, okay, if she's honest with us. Most people are. I already mentioned that. So how do we do it? We do something called the Edinburgh, which I'll talk about in the next few slides, and we do an initial screening in an inpatient setting. Once that happens, and if that determines that they have a higher risk, we'll do what's called a PHQ-9, and that'll be what you get in your annual visits. How many of you have done just a regular, every time you come in, depression screening at your annual visit? Yeah. So it's pretty normal even at every visit, right? Are the men getting that too? Yeah?
At least once.
Huh?
I think at least once.
At least once? Okay. So my son Owen, who was 16 when he had his well child this summer, and he had a specific question for the family physician, which I was pretty proud of him. I mean, he said, sometimes I don't feel like I'm worthy of different things, and I feel sad, and I don't know why. I don't have a specific event. I just feel overwhelmed, and I want to know, because he had put his numbers down, and it screened high enough for them to talk about it. I want to know if this is something that I need to be concerned about. And I was so impressed with how the family physician talked about this with him. He was so calm, and he just said, you're 16, you've got all these different things going on. What is your biggest concern? He's like, well, I'm afraid that I'm not ever going to get into college. Now, this is something has been a worry for him. He's a good student, gets good grades. His brother's at West Point. He's competing with that. And he said, I just don't know if I'll be able to get into the colleges that I want to, and I'm worried that I'll let people down, which is just so honest, so honest. And he said, that's a normal thing for you to feel. That's something we don't want you to feel that way, but it's normal. When it isn't normal, and he listed different things. He said, but one of the things I want to let you know is if you need to come in and talk about this, I'd rather you book that your ankle is sore from hockey, and I want you to come in and talk to me, and let's talk about this as well. If you're afraid to talk about it in any other way, book a different appointment and make sure you get in here if it gets any worse. And I was sitting in that room. He allowed me to be in that room to hear that. And I thought that was so good for him to actually talk about it and to have a family physician not say right away, well, this is what we need to do. We need to intervene. We do this. But let's talk about this at a further appointment, and I want you to keep coming in. Okay? How many of you feel better when you talk about something and just get it out? Let's hands high. Everybody. Hands high. Amen, Roger. Yeah, I do too, right? And so with my kids, I've really encouraged that, and I have some pretty open-ended questions that I will say to them to get them to talk about certain things, and one of which is, I'll say, I do a self-inventory and check-in and how I'm doing, but one thing I'll say to them, is there anything I have said or done that I need to ask for forgiveness for? Okay? And my kids are usually like, there is usually something I have said or done that I'm not aware of that I need to ask for forgiveness for. And then it kind of comes into another couple conversations around that. And then we're able to kind of get this out in the open, right? Because how many of you have things that when you think about them and ruminate about them over time, they become bigger, right? I know I do. And until I get it out and say that to someone that I trust, right? I might not say the person's name because I don't want them to feel badly about that person. I want to change their viewpoint about that person. But I might say to someone, I'm really struggling with this. You know, am I on point? Should I be worried about this? And most of the time it's like, why are you worried about that? Don't worry about it. Or, yeah, maybe you need to ask clarification on that, okay? I just really would encourage you to do that. And once we start doing these things and checking in with people, it alleviates some of the stress we feel in our own lives. And so this is kind of what I do with pregnant women that have just given birth as well. All right, so when you are asked, I love when people say, I just got a nice book from the dean who said I was just thinking about you. When you open up something like that and someone says, I'm thinking about you, that they care enough to send you something like that, that's a really important thing. So if you are doing that with your friends, it's important. Handwritten notes, things like that. Let people know that you're thinking about them. And I don't know if you guys are all aware of the new research that says that people in your age category, 20 to 24, are more lonely now than they've ever been due to social media. How many of you have read some of this stuff? Isolated and lonely, right? Because you're on your phones and you feel connected, but you're not really, and it's kind of like a farce because everybody's so great and doing so well and they look so beautiful and all of those different things, you know, all that stuff. So it's something that you guys need to talk about and reach out and getting, I would say, more interaction with people. Okay, that's something that's helpful. Okay, so and I'm concerned. When I read that, I just couldn't believe it. That and the symptoms of loneliness are very similar to depression, and then if left untreated, they can simulate hypertension and go into that, and some other chronic illnesses that can lead to that. Okay, so loneliness is a precursor for many different things. Okay, feeling misunderstood, right? Not heard or not loved or not cared for. All right, so what do? We got to recognize it. We got to offer cognitive therapy, what I'm doing with you right now, support groups. If we talk about it, it lessens the amount of effect that we have in our life, right? It gives it less power. I say to my kids, I want you to bring it to the light. Once it's in the light, once it's out, it has no more power. If it stays in the darkness, if it stays tucked in here, then there's nobody to sort of help you through those feelings, okay? So that's really, really important. And then also when we can work simultaneously with antidepressants. There are certain types that work really well in pregnancy, and there's certain types that work really well outside of pregnancy. So I'll give you a couple examples. If you're on a Prozac prior to pregnancy, I'm going to switch you to Zoloft, which is a little different, a little bit better. And long-term, Zoloft is a better medication overall. It talks about some of those things. All right? And then, like I said, some people feel great while they're pregnant. They have no depressive symptoms and feel like they can go off, and others need more support. And anxiety might kick in, and they might have another component that picks up, maybe a panic disorder or an anxiety that might also creep in when pregnant. Okay? So we've got to watch those closely. All right. When you think about a selective serotonin reuptake inhibitor, an SSRI, you think of those that are listed, like I'll talk to you about a few, they have a pretty minimal effect. However, some babies do have some side effects after, right? If they're getting that throughout the pregnancy and then all of a sudden they give birth and it's not there, we're going to have a few things that happen to them. It's not completely innocuous, okay? But if you think about some of the higher risk ones like Paxil, we won't give those because there's just a high enough risk of a congenital heart defect. And then we have to weigh the multi-drug sort of things that go along with it, anti-anxiety and antidepressant, anti-pan, all the stuff that goes into that. So I'm gonna look at that very closely while someone is pregnant. Okay. If someone has had a long history of switching meds and it's still a category C or D in pregnancy, we are going to weigh the risks and benefits of that medication. Okay. Now, you can imagine there's not enough people that really are willing to be tested while pregnant. Like, hey, let me give you this drug and see what happens to your baby, right? We don't have those kind of, it's not something that the IRB will let us do. But what we do know is over time when we have experienced something that's happened and somebody has taken it, and then we can look at a defect that has occurred. Okay? That's the most that we know of people and how we can test those people that are pregnant on their risk factors or categories. Okay? That's how we go about it. What happens to babies after they're born? There's a little bit of what we call an adaptation syndrome, so poor adaptation. It doesn't last for too long. A little bit of poor feeding, hypotonicity. The one thing that I want to say that's pretty consistent is this weak cry or a high-pitched, increased cry. And so it'll be very grating on your nerves. So moms will say, this baby has such a high-pitched cry, and it's hard for me to hear. Now, that is pretty rare. Most moms can handle any crying of their infant, and they know what it sounds like, okay? You know, and I was often reminded of that when you watch different types of animal programs, like with penguins. You can hear them squawking, and they all sound the same, but those penguins know exactly know where their babies are. It's similar for us. We know our babies cry. We know what it sounds like, and we're usually pretty okay with it. Do we love it? Right? We don't love it over a period of time, but we're not. It's not going to grate on our nerves. This one is different. It is extremely high-pitched, and you'll hear it in infants right away after they're born. It'll be a discrete cry, and usually it should go away over time. Okay? It should go away. There are some rare things like persistent pulmonary hypertension in infants, but if we use a Zoloft, usually we're not going to have that experience. Okay, so switching to Zoloft is going to help us not have some of these issues. Okay. All right. So, what are the psychiatric disorders? There's 3 classes, like I broke down. You've got baby blues. Some of the major mood disorders like depression and anxiety, and then you've got that psychosis. Okay. With psychosis, you don't necessarily have to have a history of psychosis to have a psychotic event right after birth. But they do happen, and they have happened right in our hospitals. And like I said, some of you have experienced as students, okay, where they start hallucinating and they start trying to either hurt themselves or other people or their baby. Okay. This is just a good slide to sort of look at how often this happens, right? Just another way to look at data. Okay. Obviously, a medical emergency is those psychotic events, but that's less than 0.1% of the time. Most people are pretty fearful of themselves right before that's going to happen, so they'll let you know. They'll let you know. Sometimes that isn't the case. Okay. If you've got a bipolar patient that has multi-drug drugs that they're taking, this might be another incidence where all of a sudden they've given birth, they've had all this happening, they have all the absorption going to the baby and through the placenta, but then also this will be a higher dose of something that's happening. It might push them a little bit. So we watch that pretty closely right after birth, okay, and start to adjust for that. Most things have to be adjusted pretty quickly after birth. If you're taking certain medicines because of that placenta and that baby. And we are all aware of that. All right, so just remembering that with the blues, normal is to, yeah.
I was just going to ask, what percentage of women who have major depressive disorder before pregnancy end up developing postpartum depression?
On that first couple, I think that second or third slide, I kind of show what happens. I think it's up to 30%. Is that right?
I don't see that on this. On the third slide.
If you've got a history of depression and you go in, is your question how many of them still have depression? So repeat the question just so I have.
I was just asking, of the women who have major depressive disorder, what percentage of those women with the major depressive disorder end up developing postpartum depression?
It's probably close up to that 30%. Okay. Yeah. That's going to be a hard one for us. You have to piece that apart. Okay. Most of us will kind of, if you've already been and been known to have this going through pregnancy, we're going to just, we're going to watch it for those 2 weeks. That it doesn't go into any other, the psychotic, but you're going to be assumed to have it. It's not going to change per se.
Okay.
Yeah.
But it's still because
yeah. Good question, though.
That's what I'm saying.
Like I said, the postpartum sort of blues can last for up to 3 days. and then in up to as long as 3 weeks. But we usually give a 0 to 2 week time frame. Okay. I say that I'd like you to be feeling yourself a little bit more like yourself, although we all know that that's going to be a little bit different for people because they're postpartum, and this is different if they're lactating, that their hormone balance will not be completely normal, but they'll feel like themselves within that 3 week time frame. Okay, I don't want to go on too far. I've gone through this, but one of the major causes of feeling down or feeling depressed can be situational, and that can be just caused from fatigue. Okay, like today, most of you are pretty tired, and you have the stress of getting here. And how many of you slept well last night? How many of you slept well? Good. Some of you just slept like a baby, like 8 hours. Good. So some people did not, though. How many people woke up several times, right? Worried or whatever. Right? So that's normal. Yeah, that's normal. I see hands in Rochester, too. Normal. Even for me, I woke up a bunch of times, too. I was watching the emails to make sure that to know if the university would cancel, or, making sure I notified you all if that was going to be the case. If you're not getting sleep, lots of studies on sleep and depression. If you're not getting good sleep or staying asleep or able to either get to sleep or stay asleep, you will have a difficult time not feeling situationally depressed at times when that happens over a longer period of time. If you are chronically fatigued, okay, you need a certain amount of hours to replenish and to rejuvenate all of those hormones, and everything's made at night, right? And also the other thing in Minnesota is that most people are depleted, or they don't have enough vitamin D, and vitamin D is a fat-soluble vitamin, and so it's required for us to either take it as a supplement or eat it through food, right? Water-soluble vitamins are a little different. Fat-soluble are stored in your fat, and they have to be metabolized to be used. If you don't have enough of it, you're going to have a difficulty sleeping. So just by giving people magnesium and zinc and some vitamin D, their sleep improves, okay? Because all of those help and work together, okay? So if you have your annual exam, something you might want to check is your vitamin D level. Okay? You want it to be at least 45, okay? They say at about 30 it's normal, but I'd like it a little higher in Minnesotans, okay? And for us women, okay? So I'd like it a little higher, and that can help with that a ton. Here are some of the signs and symptoms. We've gone through a lot of this. But again, can be a little bit confused with just normal, how we deal with being, how do I say that? Just a new mom, right? Fatigued, overwhelmed, appetite changes, things like that. So just piecing apart how much is this normal and how much of this is it extending longer, okay? How do you recover? Well, a lot of people recover on their own. For me, it was just having Ben say to me, this is normal, and some more support, and having that support, and actually helping me a little bit with the baby. Most of my kids were not good sleepers at night, so I was pretty fatigued, and they were heavy eaters, okay? So lots of time at night, okay? Lots of time up at night. And so when you can't get them back to sleep and you're so exhausted, it's helpful for someone to just take that baby and rock it. Okay? But some people don't have that social support system, or maybe that's not present in that environment. That's going to be difficult. So the key for you all, and when you think about nursing assessments, is acknowledging how she feels. The birthing person must have somebody say that they're concerned and that they want to know a little bit more about that. That's going to help a ton. Okay, and then the reassurance, either that this is going to pass, or we're going to watch it closely, and we want to hear about this. Please contact us, back right away and checking back in. The Edinburgh, like I said, is the data that we're going to gather. If you score high on that in the hospital, again, you're going to be flagged. Now, we don't assess every single patient that comes through the hospital. We assess those that are at risk. Now, for the students, you're going to do all of your patients, which is really helpful. And we do find a few people that score high because you guys have done that diligently, and that's helpful. At that time, we're going to get social work involved, and we're going to get the providers involved, and we're hoping to get maybe even psychiatry involved, We know that we can't just put someone on a med, that we have to do supportive care as well. We're not going to just put you on a med. That's just, it's not proven and it's not researched that works well. Okay? We need a little bit of the stress, that getting over that hump, but it's not going to take care of what's going on internally. The biggest red flag is anybody who wants to isolate. Okay, that's my concern with social media. My concern for young people is wanting to stay at home, not wanting to get out, which is abnormal, and to not want to engage with people. Okay, I know when I'm overwhelmed, isolation feels pretty good. Stay at home. Like today, you know, my kids are all home. I bet all of us would feel the same way. That being in your jammies and, you know, maybe watching Hallmark movies sounds pretty good right now, right? Without all that snow. But that's just, you know, sometimes that's good. That's good self-care, okay? It's good self-care to do that, to recognize those. But my hope is that you will then get up and want to do something different and find something that gives you joy, whether it's going out to eat with someone, grabbing a coffee, but getting out of the house. A key that I tell moms that are experiencing postpartum blues is my first question I will ask them is, are you getting out of the house? And if they say, no, I'm not, I'm really just staying in, I'm going to encourage them to go on a walk with their baby. I'm also going to encourage them to get to the grocery store, go have a coffee with someone. Just getting out and experiencing something different and then entering back into your home is a huge life changer, and I'm sure you guys experience that too. The other thing is I do want people to get up and get themselves ready. When you put your brave face on and you get yourself ready, you feel better. Okay? All right? Yes, go ahead, Jamie.
You said you would put these patients on meds, or you wouldn't?
No. We're just going to recognize we're going to give them some time. Now, if they have a history of depression in their family or something that's going on, and then they risk higher on that post-Edinburgh, then I'll consider that. But it's case by case. But most often with this case, no. Good question. All right. So for this one, this answers your question. What are we going to do? We're going to include them, ask them to get out, do some exercise. The complementary, alternative methods, the CAM methods, like getting a massage, yoga, putting on a candle, doing different things like that. I know I have certain things that just really make me happy, and I'll do those things, and that'll kind of calm the situation. Okay. The key too, if you're not eating well, you're not taking good care of yourself, you're not going to feel great. You are what you eat is true. So if you're eating well and taking good care of yourself, also when people actually take the time to eat well and take good care of themselves, they feel better about themselves. It's another self-care thing. All right, moving into postpartum depression. All right, now thinking about that's extending after that 2 weeks, okay? 1 in 10 women will experience this, okay? It does occur in the first year, so it's a pretty high risk that this will happen. The onset, though, really is when we start to say absolutely this is what it is that in between 6 and 12 weeks. It can happen earlier, where the symptoms just absolutely don't get better. Now, this is in Isabel, it's just kind of interesting too, where this is the one that we're in 5 to 20%, so up to 20%, it'll have this will be their very first depression symptom where they say, I'm depressed. And it'll be just the incidence of pregnancy that will get this going, okay? All right, and this is where it's just not getting better, okay? You don't wait too long on these patients to get them help. If you've already got a history of depression, this is where that 30% is, you have a high risk of postpartum depression, so that 30%. Anxiety, we are trying our best to understand anxiety, panic, and depression as a little bit different. Some of those symptoms can be different, but I can tell you if I put you on an anxiety med and you've got depressive symptoms or vice versa, some of those will break through. So we have to be very clear on how we treat people and to adjust this accordingly. Now, I'm sure a lot of you, and I'm not going to ask for a show of hands, have an experience with this. So you know what I'm talking about. Meds are important in how we treat people. So I'm somebody that actually wants to hear about how these are working within a few days. Okay, within a few days. Most depressive symptoms, like I said, go on for a long period of time, so it's going to take a little bit of time to get what we call that sort of that level up. So it's not something that is something that you need a good 4 to 5 days to a week to get that level up. In the same regard, I'm not going to want you to stop this right away either. If it doesn't work well, I'm going to taper you back down and then put you on a different med and switch you off. All right, if you have an already previous postpartum depression that's been documented, it's a 70% risk that you're going to experience this again. Keys are like if you don't have support at home, and a supportive partner, you're single, all those risk factors play in here. Okay, so we are going to want to get them in some sort of support system, whether it's complementary therapy or actually talking to someone, psychiatry or therapy in some way. All the same risk factors present for postpartum blues are the same here for postpartum depression. If you have already a case where you have psychiatric disorders documented in your chart, this is where that it plays a little bit higher of a risk for these people as well. So history plays a higher risk here. Then that last bullet. If you decided that you did not want to take your meds in pregnancy and you felt okay, you're going to have a higher risk here to have this happen post. Okay, so we're going to watch that closely. Because I think a lot of people have a honeymoon period where they're like, I feel great, I didn't need this in pregnancy, maybe I'm done with this, and they don't want to take it again. But I always say to people, if you had diabetes or you had hypertension, and you were taking a med that's going to help you and save your life, that we would give that to you without any question. So if this is something that's helping you, I'm going to want you to still do that. I'm going to treat that the same. We want to remove the stigma around this. As long as I'm determined, we've determined that this is not situational, okay, that this is not getting better. There's no problem with this, all right? Only thing that I want to talk about here, two things. One is if you've had a stillbirth or an IUD, I'm going to talk about fetal loss next week, but that puts you at a risk just in itself. That would be considered something that's a long-term processing, a grief process that could be situational and can get better once you process it. Okay, I had 2 losses and I didn't process them all that well. By my second one, I was extremely depressed. I was so down, and I'll talk about more of that next week. So that's a big deal. If I don't process it, I don't go through the grief process, I'm going to have long-term effects. So we want to really encourage people to do that, okay? To do that well. The second thing I want to talk about is we have a high-risk pregnancy, like a multi-fetal pregnancy. Those hormones are high. Once that placenta is gone, you've got a lot more hormones as well that you've got to work through. So they're at a higher risk as well for this. So we're going to watch them closer. Okay. All right, so this is a key slide. Okay. When you think about postpartum depression, the signs and symptoms of it, think about they have to have one or both must be present. Okay. They report a depressed mood most of the day. And they have a markedly diminished interest in and or pleasure in most of their really important things that they love to do already, okay? Thinking of like things that give them joy that just absolutely doesn't give them joy. And then at least 5 of the below, okay? And I don't need to read those to you, but that's what is important for you to know. That makes sense? You have to have one or both of the first 2. One qualifies you, and 5. At least 5 below in that bullet. We take this very seriously, okay, to diagnose someone with this, okay? And the signs and symptoms have to be greater than 2 weeks in general. And we do have some want to look at intensity of symptoms, and that's when the consistent examiner is really important. Like if you're not bouncing around seeing a bunch of different people and you come and see me and you book it with me, then I can look at my notes and I can look at your affect and I can look at all these things, and then I can say to myself, oh, I really do think this is something we definitely need to do, right? And remove the stigma if they're worried about that. Make sense? Yeah. Okay. So what are the signs you're going to see? Irritability, emotional lability, meaning one moment they're fine and the next moment they're crying, and then that worry and anxiety. Things that didn't used to give them too much trouble, they could work through it, not be too worried about it, are giving them a lot of trouble. Okay, getting out of the house, worrying about how they're going to manage at the grocery store, driving, worried about their baby choking, worried about their baby sleeping. I've had people that are so worried and have so much anxiety around sleep that they check their baby multiple times just to see if they're breathing, put their hand on there. That is a very hard place to be in, meaning you can't sleep until you know for sure your baby's okay. Okay, that would be considered something that is, yes, a worry for most people, but then a way to usually calm themselves is to make sure the blankets are free from the nose, the baby's on the back, that's wrapped appropriately, those different things. But when you have someone obsessing about that over and over again, which is one of the common things that happen right after birth, okay? All right, we do, the biggest thing that we can do is screen everyone postpartum. So as a nurse, we do an overall screening. We don't necessarily have to do the postpartum, but depression screen. But if you see other signs and symptoms, right, that you think that this patient needs a full screening, then you are the people to do that, okay? Again, sleep is the biggest thing, and then to alleviate any guilt or worry around this so that you take the stigma out. Once you find out what they risk out at, the number, then you are going to talk to the provider right away. Go to the charge nurse, talk to the provider. Because it takes a little bit of time to get social work involved, you want to have a visit and someone see them prior to their discharge. Okay, so that will be your job to make sure that they are not discharged until someone comes and sees them. Deal? Yeah? Why is the Edinburgh postpartum depression screening scale used at every hospital? Because it's systematic and it's objective, right? When we have subjective findings, those are really hard to give numbers to. Objective findings we can actually do something about. In order to get this at the hospitals, we have to ask for permission and pay some money to use it. It's that good, okay? It's been known to validate what somebody is feeling without making them feel bad about it. It asks a few questions over and over again in certain different ways, which those are good tools. So a validated tool is something that kind of, when you say, wow, I feel like I already answered this before, you're going to get that consistency that they're answering the same thing more than one time, which tells me that they do have an issue. Make sense? How many of you felt that way when you actually answer questions on questionnaires that we give you? That's a good validated tool. Okay? Asks you the same thing over and over again, but in a slightly different way. Annoying, but it's good. Okay? It's a validated tool. I think the biggest thing is that second bullet. And I think as you get, and you do this a little bit more often, you're going to notice that identifying who's at risk for hurting themselves is the key. It's the key, okay? And I can tell you that you can get pretty good at this. It just takes a little bit of time. If you're ever concerned, talk about this with another nurse. Say, you know, this patient seems like they have their affect is just, you know, it seems off. They're not showing much. They aren't upset for their baby crying. They're not really reacting to their baby. They're not picking up their baby. They're not doing a certain things, okay? So, you know, what do I do about that? That's somebody that you might want to check in, okay, with them, okay? If someone actually does appear to have an affect that is concerning, or you do a postpartum depression screening and they risk out pretty high, you're going to want to ask the specific questions. Have you ever thought about hurting yourself or your baby? And that's a pretty good question. Most often they will say something because they feel so bad. If they do say that, it will determine risk. Do they have a method, availability, a specificity, and really are they, is there a lethality present? Like I've already thought about a knife or a gun or something like that. If they've already got a plan, that suicide risk increases. Okay. Okay, so the one thing that I've talked about all of this, but the last bullet I want to talk about. I have people still to this day that I will go in, and I even as a clinical instructor, and they'll say to me, oh, she can't breastfeed because she's on this medication. And it's so frustrating. So if there's ever a case where you are worried about whether or not she can breastfeed because of the small amounts that go through the breast milk, get a lactation consultant in there. We have a book that we go through. Most often people can breastfeed through this. There are very few meds, very few incidences that we say no to. So absolutely not. So if you hear that on the unit, I want you to get somebody else involved, right? It used to be like, oh, I don't want to recommend that. I don't want to recommend that because what if it does hurt the baby? Well, the risk benefits of being able to breastfeed is actually pretty protective on postpartum depression. So we don't want to give that up. Right? And then there's, if you wanted to breastfeed your infant and all of a sudden someone's telling you no, that's going to increase your amount of depression from a situational perspective, that someone's taken something away from you that you think and deem that's going to be really important to you for you to be a good mother. Okay? So I really get passionate about that. It's very, very low concentrations. It might be okay for that baby anyway, so that they have less of a withdrawal from it as well. Okay? Again, this is where Zoloft comes in. It's a great med. It's a great med, and it helps a lot, and it's the one that's minimally excreted in breast milk. And then if it's a multi-drug therapy, I'm going to review each one, and I'm going to make recommendations. Let's talk a little bit about antidepressants. I think we're getting better. I think the stigma's going away. But there are some stigmas that are still present, and again, I just use that analogy. If you had diabetes or hypertension, nobody would say to you or give you any trouble with that, okay? But if it's a cultural issue where they believe, some cultures believe like that their God is just the way it is. It's just what you have to accept. That's just how you were made, and so that's something that's different. Because that doesn't play out the same way with hypertension and diabetes. So I would challenge that in just in a way that might be helpful to help you understand why something works, some medications work, and some do not. And I just there's some things that you know not to say. Always ask open-ended questions and listen to them as to why they might not be taking it. Do not give your recommendations other than, here's what it says in the literature. I know this is minimally excreted. This is why it's okay. Give them the data around that if they want that. And their partners. Sometimes partners can be your worst enemies on this, where they'll say, well, I really don't want that birthing person to take any type of medication because it's my baby, right? Well, we're not going to say that to you if you have hypertension or diabetes. So again, that's not something that we want present. It's not their decision either. Right? It's something like that. And then the whole thing about medications are addicting. There are no medication in terms of what this type of medication is, like any sort of diabetogenic or something that we give. It's not addicting. This is not have addictive properties. So let's get that out of the way. Okay, get that out of the way. I think probably the worst thing that happens is somebody is depressed and doesn't have any desire to come back and see you. So that last bullet, last couple bullets is important, especially that second to last where you want to encourage the follow-up. I want to see you. You mean a lot to me. Let's get this scheduled today. That's what I usually do, is have it all scheduled for them and then get them in to see you. And if you flag that, I used to flag some patients. I had a way to do that, and I would have somebody call them. Okay, have somebody call them and make sure they come back. Like I said, I always feel good now because in the pediatric world now we screen moms as well when they come in and bring their babies, so I know they're going to be screened at least. Okay. I just want to touch on anxiety really quick. Some of you have experienced it. There are situational times where anxiety is present. Sometimes it can be really great right before a test or something like that, where then it subsides. That's not what I'm talking about. But that is that fear of something that's really out of proportion, or the ruminating of something that is not going away, and you have no way to sort of get yourself to calm down from it. Okay. I remember, I've been through a lot of schooling. I remember just thoughts in different areas, like when I felt really stressed with a lot of papers or tests due, that I had this thing that I would say, as long as ... or as soon as, or at least when this is done, I'll be okay. I'm just going to encourage you to really pay attention to those things, that certain things like that are symptoms that you know, that if it doesn't go and it isn't the way it's supposed to be, that you're not going to be okay. Okay, I don't want that. I want you to be aware of those things. So how do we manage our stress? As long as this is happening, as long as this person says this, as long as this person isn't upset at me, as long as this happens, any of those kinds of things you want to pay close attention to as ways to cope. But if you get to that place where somebody is actually now ruminating to a point where they are fearful, I don't want to be left alone with the baby, then we need to talk about it. Now, we have a mechanism in the Twin Cities that any mother, birthing person, can drop their baby off at an ER and leave their baby there, and there is no judgment whatsoever. Okay? They literally come to the ER and drop their babies off. And we take that baby and we say thank you very much. We have a few things that some information that we take, but that policy is present within the Twin Cities. Okay? All right, so we know that people are able to do that. We will find a home. We take that baby right into the special care nursery or the NICU or somewhere where we need to take close watch, and then we'll find a home for that baby. Okay? All right, now just making sure we understand that panic, post-traumatic stress, and obsessive compulsive disorder are all something that you will see in these people, and we term it all under anxiety disorders. Okay. Some people might not know that they have OCD until they are pregnant or they're giving birth. You might see it pop up there. You might see panic pop up while they're giving birth. Okay, all of a sudden they start fearing something. The baby's coming out, the head's coming out. You start seeing some of these types of behaviors. Okay? I try to do a really good history on if they've ever experienced anything like this. Now, some people repress that they've been abused, sexually abused, or emotionally, physically abused, and that'll come out in birth. Okay? So all of those kind of fall in. Right? When we think about a psychosis, though, again, a couple things I want you to remember. Medical emergency can onset anywhere from 2 to 14 days, so that happens pretty soon. They're going to have it. Very, very rare, 0.1 to 0.2%. However, of those people, there's a pretty high risk of suicide or infanticide. Okay, the risk is at 5% and 4% for those two things. Okay, high enough. Right? The biggest risk factor that we have for people are just untreated bipolar. Okay? If they've already had a previous psychotic event or psychosis, and severe prenatal stressors when you see it for the first time. Okay? You pretty much can tell when someone's in a psychotic event. Okay? They're not talking rationally. They might not be able to remember things. They have paranoia. I think the ones that I've had, the biggest clue for me was paranoia. Thinking that people were coming in to get them, that they were going to steal their baby, hurt their baby, that they wanted to either hurt their baby, I was going to hurt their baby, not recognizing me when I came in, thinking that I was somebody else, thinking that somebody else was coming in, that they were disguised as somebody that was going to come and steal their baby. Stuff like that, where you're trying to figure out what, wait, no, I was just in here. Remember, I'm your nurse for today. Those kinds of things where you have to remind them of certain things. And then over like a period of time, you're like, yeah, this is not good. This is not good. Okay. So both, just look at the mental and behavioral terms. That'll make sense for you because we've gone through a lot of them. When you have something that this happens, you're going to get a team. You're not going to leave her. You're going to get a team in there. And someone's going to get the baby safe, and one person's going to get the mom safe, right? And we usually have what's, we either say code brown for mental health or something that's going to be mental health, and you'll get all the people that'll come to your room to help with that. Okay? Again, this is another one where you don't leave or you stay there unless you're at risk, right? You get somebody right in. You can yell outside your door, but be in there. I need help right now, and get people in there. Okay? If someone has a psychotic event, we document it pretty thoroughly. It's in the chart, and then we also try to get her the help before another pregnancy happens. Okay, before another pregnancy happens. I got a question last time. Oops, sorry. I got a question last time where it was, look, does the baby just get taken away, and the mom doesn't get to be a mom or whatever? That's not always the case. We'll get the baby safe, and then we'll kind of determine what happens with that. Going forward. Okay, so there's an assessment that goes through. All right? Okay. Now, we're done with this slide, these slides. What we're going to do is we're going to take another break, and I've got our guest here that's going to talk. I'm going to have you do about another, let's have you come back at 10:10. Okay, another 15-minute break. I see some of you, you're hanging with me. Some of you are pretty tired. Okay, so get up and move around. And we're almost there, okay? So.
All public schools. All public schools. Parents are allowed to be assigned about during my mom works at Boston. Okay. We have one. Yeah, but that's. Did you read? Following class is like Tuesday. 30 minutes late. But I'm about to like, hey. First of all, they're saying out of the
I don't think my I went into my ATI guidelines, and it says like over there. It does say that. Okay, guidelines. That's why I was gonna. But what are they doing? Yeah, like it's this one.
Okay. I've been there before. It's not like that.
So what? I can't get it in the I think I have to go to the firehouse.
Okay. Well, those are like the only places that
so I have it in me.
Do you want to eat that? Yeah. It's the same. I have this. It's like, oh yeah. Oh wait, no.
The only reason that you got I have to have it on and televised. So you want to pull it up on your and even just kind of keep track on it. That work? Now you have to
Oh, I think it's good.
Your slides.
Four sentences. Paragraph. I'll let you know when it pulls up. The wheel. That's fine. From around the world. If they're actually cool.
Kind of like a cover, way better.
Why don't you? Did you send it to my email?
I didn't, but I can.
Why don't you do that and I'll? Yep, I'm gonna put it right in here.
All right.
Why is?
Because that's not the one that we.
No, it is not.
Good.
If it says 2, just go by. not going to necessarily. Originally led to us forced in there to do it.
Well, like,
Some people weren't doing anything.
I felt.
I did some of it, but doesn't matter. I was just
Yeah. I just feel like it was helpful, like, during the exam, like, studying, just because it was so much in-depth and, like, not everything really going on.
yeah.
I just felt like there's a lot more content in there that we didn't know.
But not yet. I'm trying to prepare for like maybe just that portion because it can be only I only history on a certain amount of stuff.
Yeah.
But when you do the ATM recruitment, you're gonna have to do both.
Do both?
Yeah.
Okay. Okay.
Is that helpful?
Yeah.
That'll be probably the best for you.
Okay.
Yeah.
Okay. I know. I realized that after.
Yeah, if you send it.
Really going to school.
Yeah. I feel bad for them for doing that. I'm tired, but I'll still be with me. They can watch it.
My mom and my friend and her mom are coming.
Yeah.
It's a nice restaurant, but depending on the time, really, there's not that much space on the rooftop. We had a party of 7, that's why we got our own block.
There's a snow emergency
Like it
for
feels
any
like-
of you who it starts tonight, just FYI.
Oh, I hate
On the
them.
opposite side of the park.
They make us move though. They're like, you have to vacate this area from this time to this time. And I'm like, okay, where am I supposed to go? Then where would I go?
Where?
What time is it? Oh, if I go to Boynton.
So, if you leave it, this one it is, if you open it, actually, oh, you mean for a drink?
Where
I need to do that though.
For your 813.
Oh, gonna be in public health.
It's such a is she gonna? The library rides? No, she's walking through. So they were.
Yes, they did.
Looking at light.
Whether, you know.
Okay, well, I was curious if.
As a whole, and
You might.
They all made it.
Okay.
Quicker for
Some of them were. Okay, so I thought it's this.
Fill out some facts. Oh, we did. You can get 400 miles right away.
I can't. So whatever. You know. So that last semester she. What? But it's like in there.
And Barbara, listen, are you writing? I was like, I did.
But a long time ago. I like chat. Because I'm trying to like like I love all the things.
I'm so tired.
Or if you're sitting down, those might stop in your lap. Yeah. I had like that's my
And I
actually I really should work out my daughter, but then like I'm gonna lay in my bed and watch it.
actually they didn't. It doesn't matter. They probably get it.
Yeah, I sent you a picture of my shirt.
Makeup thing.
Thank you. I wonder if that's work that I want to on call.
No, that's like a makeup thing. Like a makeup.
Better not. Yeah. And I was like, oh, do you have to go? Seems a little like that. Yeah, I didn't make any. My first last semester.
That's so freaking. I only copied what's.
Well, we can type it. I think it's just do it on pasta.
Or she did it last.
Then I can work 40 hours.
oh, I think the adults want food and
Yeah.
every senior.
I know you did. I saw you. I was wearing
Awesome.
You're in Korean.
Oh, I was filling out my.
There's that one from one. Put it for there. I was like, oh, hey. What? No, like I had to take it because I have to do it for like 2 hours. Other than like stay on the phone. That I did actually. That's why it's like I have the voice. I don't know. But they're gonna again. So I think these are very bad. Because I don't know, like my TV, it's always like you're like, and she would wake up. Oh my god, I just tried to like all this stuff you can work I do. There it is. And my son goes talking about them, and I haven't ever done. And they have Raj. The Raj up there.
Just, you know, this and this.
Then I do background check, an occupation. And I like I promise the inside won't be I saw one girl behind Paula. Oh, I'm no way. That's so funny. She was right there. I was having a bad way. It's odd if you guys like saw each other before you went off. Or not looking at them. No, I just like got them. I saw her get on. It's just like a TV. So I got them. So you went okay, and I'm going I know.
I know where it is.
Yeah, she like
You get but 70 minutes.
yeah.
Which I think you should go on. That's what
like, hey, that's what should take I just want to work with Erica. Can't wait to see. No, apparently.
The high voice.
Next day.
Like I did. I couldn't think of a picture for garbage handbook yesterday.
Yeah.
And it was after they had their first
Yeah, that was us. This is hard because that's why we're bored now.
I didn't
Semester.
I like the ones I don't watch anyone, but I like going back to the
like snapshots a week that we
Yes.
Oh yeah, the one other one.
That's a voice to it. It's a little different.
Yeah, that's a little bit.
But
Oh yeah, that.
yeah, voice to it.
Or diabetes one the first.
Okay.
I got a few.
Yeah. Yeah. The first week was too hard because it's 3 lectures and we're
I like feel like
yeah.
but at least I feel like I'm too excited for me.
Yeah.
Today.
I could do that if I would get on.
Okay, recognize.
I like the strawberry. Don't they have like cinnamon roll?
Girl.
We're the best.
Oh yeah. They also. Yeah. Actually, you know, it's fun because it is a whole different.
Okay.
I don't know if I get all in
No, I could do 95 one big class. Okay,
there was a couple
roll this morning. Yeah, those are really
That's weird. That's
It's almost weird. I was like,
like
it's a commercial.
Oh yeah, for me. Oh, actually, it's crazy because I'm trying so hard to raise them. No.
I really you were playing.
I know I was playing but I was just typing. Let me introduce you.
Okay.
I'm going to get you started. All right, everybody. Go ahead and get started. Okay. Great. All right, we've got Dr. Elena Geiger-Simpson here today. And I think she's taught at least some of you before in your psychopharm course.
You are familiar.
Yeah. And so I'm going to let you tell them a little bit about yourself just to refresh right now. So she's here to do a guest lecture on the child adolescent psychiatric disorders. I think it's going to be pretty helpful for you to do that for them. Okay? So
I understand that you all have had a pretty long day today. Do you have an exam? How'd it go?
Not good.
Okay. It's done now, so now you can't do anything about it. Hello, Rochester. Can you hear me okay?
Hello, we hear you well. Yep.
Great. I'm not in the courses that I teach. I don't do ITV, so it's kind of fun for me to see Rochester folks over ITV. My name is Elena, and I'm a psychiatric nurse practitioner. I work in a primary care clinic, so I work with people across the lifespan, but have a particular interest in working with children and adolescents. I also teach on faculty here at the university. I teach in the Psych Mental Health DNP program, so future psych nurse practitioners. I've guest lectured for a couple courses in the BSN program, so some of you look familiar from that. I will try to make this quick since you guys have had a really long day already, and try not to put you to sleep.
I'm so hot.
So today we're going to talk about children and adolescent mental health conditions. 1 of every 5 children and teenagers have a diagnosable psychiatric disorder, and this is likely underestimated. The rates for adults is about a quarter. So about a quarter of the population will have a mental health diagnosis within a year. Most adults with mental health disorders have had symptoms by the time they were 14 years old. So mental health conditions are starting earlier and earlier. Suicide is the leading cause of death among youth who are aged 10 to 24. So this is a pretty significant public health issue. The leading cause of death, suicide. 1 in 4 parents have trouble accessing mental health care for their children. So this is another problem. If any of you are interested in going into mental health, there is a very significant shortage of mental health providers, especially for children and adolescents in the country. People wait months, up to 6 months, to get in to see a psychiatric provider. So there's a huge gap in services and a huge need. So if any of you are interested in mental health, come talk to me. I'll convince you. You all have learned about social determinants of health, correct? Yes? Okay. I'm going to review them again because they're really important. Social determinants of health are factors that influence a person's risk for disease and their vulnerability to illness. You can see up on the slides that there are a lot of things that put you at risk of having various health conditions. Economic stability. Research shows that folks who are more economically stable, who have more money, have better health status than folks who live in poverty. Food insecurity, housing instability, poverty. Education. Also, folks who have more education tend to be healthier than individuals who have less education. I'm always curious as to why in Washington, our education folks aren't talking with our health folks, because there's such a huge correlation between education status and health behaviors. Social and community context, so discrimination, racial differences, incarceration, social cohesion, access to health care, access to primary care. A lot of people don't have access to health care, so how can we help promote healthy behaviors for folks who don't have that access? Neighborhoods really impact people's health. So if you are a kid who lives in poverty and you don't live in a safe neighborhood, how are you going to get out and exercise if you don't feel safe leaving your house? If you are exposed to ongoing trauma within your house or abuse, how are you able then to maintain your mental and physical health? If your family can't afford healthy foods, those are all things that impact our health. So here are some examples of various health disparities. Children from racial and ethnic minority groups are 1/3 to half less likely to receive the necessary mental health treatment than white children, despite similar prevalence rates. So the rates of mental health are similar among racial and ethnic groups. However, that disparity of access to care is there. Only 1 in 11 Latinos with a mental health disorder contact a mental health provider, and only 1 in 5 contacts a primary care provider. So again, why is it that folks aren't able? Are they not able, or are they not? What are the barriers that are getting in the way of them accessing care? Corner stores are 38% more expensive than suburban big box stores. So again, if you're living in an urban area, in an area of poverty, and you only have access to corner stores, you're paying more for the food, and often not healthy food that's going to help promote your health. 1 in 8 households moves in urban areas due to involuntary displacement. So they're not able to stay in their homes, so they get stuck moving to urban areas. Children from middle-income families have twice the vocabulary as poor children by 1st grade. So again, that education disparity and that social determinant that impacts our health. I have, my best friend is a 2nd grade teacher, and we talk, she talks a lot about her work, and I talk a lot about my work when we get together. And she was telling me this story of one of her 2nd grade kids who's moved, I think he had moved 8 times since the beginning of the school year, and how that had started to impact his learning and also his mental health. He was starting to exhibit symptoms of depression and anxiety, some other behavioral symptoms, because he had moved. Prevention. So what can we do to help prevent mental health conditions among our young folks? Positive reinforcement, reinforcing positive behaviors for our people, or for our kids. Promoting independence and control within their developmental level. When we give kids more control, when it's appropriate, that fosters more independence, increasing their self-esteem, making them more confident, building resilience. In addition to giving them more control, also setting limits. I talk with my patients' parents all the time about setting limits on technology, as you all are looking on your computers because you're typing notes, of course. But I talk a lot about limiting people's setting limits, whether it's having their phone or iPads or video games or making sure they're getting outside. But limit setting is really important for kids. They need it. It's not always pleasant for adults, for parents, but it's really important. Rewarding positive behaviors. So that, again, goes along with positive reinforcement. Fostering competence and independence in kids. And again, this has to do with, what's appropriate for their developmental level. But this help them build self-esteem, and it's a protective factor. So when we foster competence, it increases their self-esteem, which is protective against anxiety and depression, right? Folks with higher self-esteem, feeling better about themselves, more competent, more skillful, it's protective against developing anxiety and depression. Teaching kids about emotions. This is something I do all the time with the kids that I'm working with. First, you got to teach them names, right? We don't always have a name for the things that we're feeling. So when we can teach kids how to name their emotions, then they can put a name with how they're feeling. And they can talk about the emotion that they're feeling. I don't like talking with kids about good and bad emotions because we all always have the full gamut of emotions, right? That's part of being human. We feel sad, we feel angry, we feel happy. And those are all perfectly normal emotions. So when we can teach kids, well, that is what you're feeling, anger is what you're feeling, let's talk about it. Let's talk about what you're feeling in your body. So it helps them understand their feelings a little more. allowing kids to struggle with challenges. This is something that I think parents sometimes have a hard time doing because they want to protect their kids and they want their kids to succeed. So watching their kids fail and struggle is difficult. Yet this is very important in helping them develop that independence and that ability to problem solve. As you get older, as you move into college, as you become young adults, as you become middle-aged adults, you are always going to have problems. There are always going to be issues. The world is not perfect. So being able to problem solve when those things come up is an essential skill, and the earlier we can teach it, the better. Socializing, building community. Humans, we are social creatures, so having that social community aspect is really important. Making sure kids are socializing with other kids and other adults. Also, frequent screening is important. We're doing a much better job in primary care clinics of screening for mental health conditions. I was just listening to NPR this morning, and in our governor's budget for this year, they're talking about increasing funding for non-education individuals in schools, so like mental health professionals. And encouraging healthy family experiences. This is another thing. In today's society, we're busy. Our kids are going from basketball to hockey to choir to pottery, everything. They're busy. They're busy people. And that has created some problems because it doesn't allow for that time, that family time. Family dinners aren't really a thing for a lot of people anymore. And that those family experiences and conversations are really important in kids' development. As nurses, as future nurses, it is your responsibility and your role to help provide parents and kids with resources. We're going to review several different mental health conditions today. We're going to specifically talk about depressive disorder, anxiety disorders, autism, ADHD, oppositional defiant disorder, and conduct disorder. The non-bolded ones on the screen are other mental health conditions present in children and adolescents, but we're not going to touch on them in detail today. All right, if you can take one thing away from my talk today, this is it. All behavior has meaning. Every single behavior a child exhibits has meaning behind it. I recently, just a couple days ago, read a quote by Jessica Stevens, who's an educator, and she says, "There is no such thing as a bad kid. Just angry, hurt, tired, scared, confused, impulsive ones, expressing their feelings and needs the only way they know how. We owe it to every single one of them to always remember that." So with behaviors, again, I think we simplify it often and we think about, well, that person's behaving bad or that person's behaving good, right? We have good and bad behaviors. Behavior is really just the tip of the iceberg. When we look at all of those other things underneath the iceberg, it gives us a little more empathy and a little more context to why the child is exhibiting that behavior. A lot of things underneath the iceberg have to do with some of those social determinants of health. Are they hungry? I notice my sleep doesn't have an L. It says sleep. That should be sleep. Usually I'm really good at picking up on spelling errors. Anger. Are they feeling sad? Are they having emotions that they don't know how to express? But these are all things to think about when people are demonstrating what we might call bad behavior. So all behavior has meaning. And it's our job to figure out what's underlying that behavior and how to address that piece. We'll break down our mental health conditions really into two different categories, externalizing and internalizing disorders. So our externalizing disorders have symptoms that are characterized by kind of externalized behaviors. So these are maladaptive behaviors that are directed towards the person's environment. And diagnoses that fall under this externalizing category are ADHD, so attention deficit hyperactive disorder, oppositional defiant disorder, ODD, and conduct disorder. And we'll talk about all those three. And then we have our internalizing disorders, so anxiety disorders, and there's lots of different diagnoses underneath kind of the anxiety disorder category, as well as depressive disorders. And with internalizing disorders, people are really kind of keeping those feelings internal. So they're really kind of struggling internally. Although they might have some symptoms that are externalizing, like irritability. All right, so we'll start with the externalizing. ADHD, attention deficit hyperactivity disorder. You've probably heard about ADD and ADHD. ADD, a few years ago, we transitioned our diagnostic manual, or kind of our book that gives us the diagnostic criteria for mental health disorders, and we took out ADD. So we no longer have ADD. It's all AD under the ADHD umbrella. We have three types of ADHD: inattentive type, hyperactive type, and then a combined type. So it's combined with the inattentive and the hyperactive component. So 5 million children between the ages of 3 and 17 have ADHD. It's often a lifelong condition, so people often live their whole lives with ADHD. However, some kids kind of grow out of ADHD. There's a genetic component. This is always really fun for me when I'm doing a psychiatric evaluation on a kiddo who clearly has ADHD and parents are unaware of their own ADHD, and mom is sitting across from me and say, as I'm asking all these questions of the kid, and she says, "Oh, that sounds a lot like me," and I'm thinking like, yeah, that's because you have ADHD too. So it's highly genetic. It's always really fun for parents that have this light bulb that go off and they're like, I don't really struggle with those things too. I'm like, because you probably have ADHD. So criteria for diagnosis: inattention, so not being able to pay attention to details, cannot stay on task, trouble organizing, hyperactivity. That's kind of what a lot of people think of when they think of ADHD, the kiddos who can't sit still, who are jumping all around, running around the room. And with hyperactivity, we have to really think about, is it appropriate to their developmental level and to the situation, right? Some situations, kids are going to be more hyperactive. Younger kids can't stay still because they haven't developed those skills yet. So, hyperactivity that's outside of what's expected. Impulsivity, blurting out answers, interrupting. These are kids who I like to say they kind of lack their filter. So they just kind of say whatever they're thinking without filtering, like, should I say this? Is it an appropriate time to say this? But they kind of lack that filter, so they can be really impulsive. Boys tend to have higher rates of the hyperactive type of ADHD than girls. Girls tend to have more of the inattentive type. I often see girls getting missed or being diagnosed with ADHD late because they're not the disruptive ones in class, right? They're sitting there having a really hard time paying attention, but they're not disrupting class. So then teachers are talking with parents saying, well, you might want to get your daughter in to see somebody because they're not just being disruptive. I see this a lot in girls, boys too, but mostly with folks with the inattentive type of ADHD because they're not being identified early. They work really hard to manage and to compensate for their inattention and their inattentive type of ADHD and end up having more anxiety, which again kind of compensates for that inattention. And then because they struggle so much or can struggle so much, can lead to depression. So I see it's not uncommon for me to see in clinical practice a combination of ADHD and anxiety. And sometimes when we treat ADHD, their anxiety and their depression impacts or improves, so we don't have to treat those things. Oppositional defiant disorder. I don't like giving this. I give this diagnosis to people, but I'm really careful with putting this diagnosis on a kiddo. It tends to hang with them for a long time. It has pretty significant connotations and stigma around it. So with ODD, it's defined by a persistent pattern of angry, irritable mood. So easily annoyed, angry, has a real quick temper. They're argumentative and defiant, so argues with authority in adolescents and adults. They refuse to follow rules. They purposefully annoy other people. They blame other people for mistakes that they make, or for their mistakes. And when you think about, we use the word defiant often very liberally. And when we think about defiant behavior, I like to think about what's behind that behavior. Are they actually being defiant, or are they being impulsive and they're not kind of intentionally doing it? So really sifting out, is it something they're intentionally doing, or is it, which is defiance, true defiance, or is it something that has more to do with impulsivity and they don't really have a lot of control over their behavior? It's also characterized by vindictiveness or being spiteful. The symptoms of ODD must last at least 6 months and be pretty persistent in interactions with a person who is not a sibling. So if they're only having these things with their sibling, they can't have the diagnosis of oppositional defiant disorder. And it's not always present in all of their settings. So they might be having all of these things at home with parents or with other family members other than siblings, but at school they're perfect little angels. So it doesn't have to be present in all settings.
We have a question here in
Rochester. Hi, Rochester.
That's what they are, but yet you said, I don't like to label them that because it sticks with them.
Yeah.
But if it walks like a duck and quacks like a duck, then it's a duck.
What was that? Oh yeah. If it's quacking like a duck, then it's a duck.
Hey, why would you change the diagnosis? Because
Yeah. I don't change the diagnosis. I am very cautious about the diagnosis. I do kind of even further assessment to make sure that there's not something else underlying that's causing the behaviors.
So when we miss that,
yeah.
They go and grab a gun and start shooting up because we felt we didn't want that stigma on them. You know what I'm saying? It's like a double-edged sword.
Yeah, that's a great question. And it doesn't mean that I don't treat people. You know, when I think about treating mental health conditions, I treat symptoms that are impairing their functioning. So if I come in with somebody who's really angry, and again, sifting out, like, is it trauma? Is it ODD? I give the diagnosis of ODD, and I work with kids who have ODD. I'm just a little more cautious of like slapping on that label right away. But again, if they have these just because I'm cautious about putting on this diagnosis doesn't mean that I'm going to not be treating these symptoms. That make sense?
Yeah.
Okay. And we'll get to. I'll touch base with you on the kind of more risk for violence and risk. You know, we talk. There's a lot of gun violence in this country for a lot of reasons, and I could have a whole other lecture on that. But not everybody who shoots up a school has a mental health condition. Because they may be evil, but evil isn't a mental health diagnosis, right? I think we get into trouble when we start blaming gun violence on mental health. The statistics really don't back that up. People living with mental illness tend to be victims of crimes and violence more than perpetrators of violence. So it's something that the media really likes to touch on a lot. You know, it's gun You know, there's a shooting, it must be a mental health problem. And it's often more than that. Just because somebody's evil doesn't mean they have a mental health diagnosis. It doesn't mean that their thinking is clear, but it doesn't necessarily mean that they have a mental health diagnosis. Does that make sense?
Yes.
Okay. But that's a great question. I don't know your name, but I see you number 23. Hopefully you're a Jordan fan. Corey. Okay.
Jordan.
Thanks. Well, I don't know. I'm old. I mean, I'm not that old, but Jordan was around when I was young.
He knows Jordan.
Okay. I'm going to keep going. Thank you for the question, Corey. Conduct disorder. So here's continuing kind of on the externalizing behaviors. So conduct disorder is a little different than ODD. So you still get those defiant behaviors and the anger and the irritability. But folks with conduct disorder are the kids who are hurting animals, who are breaking into things, who are stealing, who are destroying property. So it's really that kind of external harming or destroying other things that makes it conduct disorder over ODD. Conduct disorder might be present in adolescents with ADHD, so there's kind of sometimes a correlation there. There's a genetic vulnerability to conduct disorder. Folks with who've experienced abuse, or trauma as younger kids, are at higher risk of developing conduct disorder. And then again, and here's kind of touching on Corey's note, is it a true separate thing, the conduct disorder, or are they demonstrating these behaviors and symptoms because they experienced abuse when they were a kid? So really, and there's a lot of really good research and more research coming out about trauma and how trauma impacts our brains and changes our brains and impacts our mental health. Poor family functioning. Folks are at higher risk of having conduct disorder if they have a parent who has antisocial personality disorder, substance abuse, mood disorder, thought disorder, ADHD. And then folks who come from a socioeconomic disadvantage may also be at a higher risk factor. And again, probably more related to the trauma that they've experienced. All right, some more character. Yes. What's your name?
Natalie.
Natalie's got a question here in the Twin Cities.
So we might have said this, but what is how do you tell between conduct or oppositional defiant? What's the main sign?
So the question was, how do I kind of differentiate between oppositional defiant disorder and conduct disorder? And that's really, with conduct disorder, you have more kind of physical destruction. So you might be destroying property, or these are the kids that set fires to things, or harm animals. With ODD, you don't have that kind of physical destruction of property. Does that make sense? Okay, that makes sense, Rochester? Awesome. All right. Some more characteristics of conduct disorder. They lack empathy. So again, when I'm diagnosing people and trying to sift out, is it defiance or is it impulsivity, I'm really thinking about that empathy, what's behind it. Do they have the capacity to express empathy? In our brains, there are things that can actually increase our ability to express empathy. Mindfulness, meditation, actually increases our ability to express empathy, which is fascinating and tells you how we can actually change our brains. And trauma changes our brains in a way that makes it sometimes harder to express empathy. Low self-esteem, temper outbursts, unable to handle frustration. Some of those characteristics are also present in ADHD, the temper outbursts, unable to handle frustration, and also ODD. The behaviors of the conduct disorder, they lie, they con others, they might run away from home, they miss school, they bully other people, set fires, use weapons, and sometimes force sexual activity on others. So those are some behaviors. All right, temperament. Whenever I'm doing a psychiatric evaluation, of older kids or even 8-year-olds, I'm asking parents about how's their temperament? What was their temperament like when they were really little? Folks who have externalizing disorders, so again, ADHD, ODD, and conduct disorder, tend to have higher anxiety, be more distractible. They're really intense folks. Poor reaction to new stimuli, poor adaptability, so that ability to change and be flexible isn't always there. They're strong-willed, and they have a kind of a negative persistence. Low sensory threshold, so again, kind of that ability to tolerate things, and a negative mood. So that's kind of their temperament. Now we're kind of shifting gears to autism spectrum disorder, ASD. Again, with our change in our diagnostic manual from the DSM-4 to the DSM-5, it used to be that folks had that there was autism disorder, and then there was also Asperger's. With the change to the DSM-5, Asperger's is no longer a diagnosis. So folks who formerly had the diagnosis of Asperger's are also on the autism spectrum. So it's just one kind of spectrum. With folks who were formerly Asperger's, or formerly had the diagnosis of Asperger's being kind of higher functioning on the autism spectrum. The cause is really unknown. There's a lot of research trying to find or getting a little more information about some of the causes of autism. It's characterized by impaired social skills, communication problems, and repetitive behaviors. Folks with ASD also tend to be very rigid in their thinking and inflexible in their thinking. So they can't really take others' perspectives, or if something is a certain way, it has to be that certain way. So kind of in that inflexibility. These difficulties can interfere with their ability to function in school, academic settings, employment settings, and in their social relationships. Folks living with ASD are also at higher risk of developing other psychiatric conditions, so things like depression, anxiety, and ADHD. There's actually a high number or percentage of folks who have ASD who also have ADHD. When I was in school, I worked with one of my preceptors who I worked with for 3 semesters. She kind of specialized in working with kids on the spectrum. And we had this term called the trifecta because we had lots of folks who had anxiety, ASD, and ADHD. So kind of treated all of those things at once. Rates of ASD are about 1 in 68 in children. Yes. Oh, you have a question?
No,
You're just stretching.
Yep.
Okay. Keep stretching. Boys are 5 times more likely to have ASD than girls. Certain genetic disorders are associated with an increased risk for ASD. Fragile X, I have a hard time saying this one, tuberous sclerosis, which are benign tumors that grow on your brain and other organs, but they're benign, and Down syndrome. Some drugs during pregnancy increase folks' risk for developing autism. Immunizations do not increase a child's risk of developing autism. I just gotta throw that out there. Okay, so the spectrum. I like this this slide because it kind of shows you the spectrum. You know, everything on the spectrum. So again, no longer ASD and Asperger's. Folks who formerly were diagnosed with Asperger's tend to be kind of on the more gifted side of the intelligence. They tend to be able to interact socially a little better. Their communication's a little better. So things tend to be kind of more on that. If you're looking at it, the right side of the spectrum. Yeah, so this kind of gives you, and some people with autism, we kind of look at all of those different things and see where they fall on the spectrum. And just because somebody is really gifted with their intelligence, their behaviors, so their repetitive behaviors might be really intense. So it's not necessarily all kind of on the same spot on the spectrum for all of those various things. All right, common characteristics in inflexible and explosive children. So folks, I don't really like that title. So folks who tend to be more inflexible in their thinking and have more explosive behaviors. I should retitle that. They tend to have a difficult time managing frustration emotionally. So these are kids who get really frustrated. That was me when I was a kid, actually. They have a hard time modulating and controlling their emotions. Their threshold for frustration, to tolerate frustration, is really low. And then they have limited flexibility and adaptability, so they don't do well with change. So a lot of kids that I work with who are on the spectrum have a hard time with transitions, with change. If I'm working with folks on the spectrum who have divorced parents and they're going back and forth between homes, that can be really challenging for folks. So they have a hard time with flexibility and adaptability. And they tend to be more concrete, rigid, and black and white in their thinking. Some more characteristics. The response to consequences. So if they have a consequence to their behavior, it tends to be continued meltdowns. They're unable to utilize the motivation from consequences. So they can't use consequences that they've had in the past to help motivate them to change their behavior in the future. Explosions can be out of the blue for seemingly no reason. They may be especially inflexible about specific issues, so like sensory things. So I think about like bright lights in grocery stores tend to be really hard for some folks on the spectrum. Tags, clothing tags, can be really bothersome for folks. Textured foods. It's not uncommon for me to work with a kid who's on the spectrum who has very odd eating patterns and doesn't eat a variety of foods because they can't handle the texture. Things might have to be in a certain order. If they have stuffed animals, they might have to be in a certain order. So they tend to be just a little more inflexible. Deficits in executive functioning. So kind of our thinking. Executive functions are a set of processes that all have to do with our ability to manage our emotions and our resources in order to achieve a goal. So we think about kind of organization. Executive functioning skills include paying attention, regulating emotions, keeping track of what you are doing, understanding different points of view, so being able to take somebody else's point of view, initiating tasks and staying on focus on task until that is completed through completion, organizing, planning, prioritizing. So folks who have ADHD have a hard time with their executive functioning. Folks who have ODD, ASD, some learning disabilities, have a hard time with their executive functioning. And folks who have that low frustration tolerance and temper outbursts can have deficits or problems with their executive functioning. So errors in executive functioning. Again, when you can't, when you have deficits in your executive functioning, you'll have a hard time with organization and planning, anticipating problems, forming goals, strategizing, problem solving, your working memory, which is really your ability to, I like to think of working memory, you hear something and then you have to hold on to it and manipulate it. So for folks so I'm really bad at holding on to phone numbers if somebody tells me a phone number or a name. Zoe, where's Zoe? So Zoe just introduced herself to me earlier today. And I have a hard time with my working memory is a little slow at times. So when she told me her name, I have to be extra intentional about, okay, Zoe. And then, I don't know, 2 minutes later I said, your name's Zoe, right? And that helps kind of solidify that in my working memory. So being able to hold on to things short term and manipulate them. Ability to define a problem, and then foresight and hindsight. So being able to kind of take what has happened in the past and use it for future behaviors. These deficits are present in adults as well, and older adults, especially with cognitive problems. And a lot of errors or deficits in executive function can be treated or worked on. So there are strategies, behavioral strategies that you can use. Those like apps that have brain games. Lumosity is a really great way of improving your executive functioning, and therapy. So most folks who I see, I always highly encourage them to also be in therapy. Deficits in social learning. So these deficits are observable in children with ADHD, ODD, conduct disorder, ASD, and learning disabilities, much like the executive functioning. And social skills are paramount in developing and maintaining relationships, social relationships, and getting along with people. So folks who have ODD, conduct disorder, ADHD, ASD, sometimes have a hard time getting along with people because they have deficits in their kind of social emotional relationships. So reciprocal communication, not interrupting people, defiance, being defiant, understanding jokes, being able to feel empathy, appropriate facial reactions. You know, I work with a lot of folks who, a lot of my folks who have ASD have really poor eye contact. So I work with them on maintaining eye contact when they're speaking with people. So these social deficits can cause impairment in their social lives. The ability to process social information, so to take in that information, like you might, if somebody's facial expression is telling you that they're sad, a lot of us, without these impairments, can identify by somebody's face if they're feeling sad. One impairment in folks who have struggled with this is they're not able to to read those facial expressions. So it might be really easy for me to say, well, that person over there looks sad, but if my patient with autism looks at them, they might not be able to identify that that person is feeling sad just by the way their facial expression looks. So again, there's lots of ways that we can work on, this is what a sad face looks like. This is what an angry face looks like. So lots of ways to treat that. Paying attention, so thinking steps for social processing. So a lot of us think about these things automatically. You know, we pay attention to social cues. We connect cues to past experiences and relationships that we've had. We plan about how we want the situation, the interaction with the person, how we want that to turn out. We consider how we might respond. We evaluate different responses, possible outcomes, and then we respond. So those, all of those things can be challenges for folks with these deficits. Delays in development. So delays in development can be present as well. These behaviors are not intentional, and the child just needs extra help learning how to act and respond. Assessment. Getting a thorough assessment is really important, especially when diagnosing mental health disorders. There's a lot of overlapping, if you haven't already seen, with our ADHD, our conduct disorder, and our ODD. There's a lot of overlapping symptoms among our diagnoses. So getting a really thorough assessment can be helpful in kind of determining a more specific diagnosis. When we're interviewing, we consider the child's developmental level. Again, like, should they be able to speak at this certain age? Are they doing more parallel play, or are they interacting with their peers? Parent-child interaction, attachment, separation, attention. Whenever I'm doing a psychiatric evaluation with a kid, I interview kids separately first, and I actually assess, when I pull them away from their parent, how they separate from their parent. So just by watching how they come with me back to my office is a piece of information for me. Were they able to easily separate from them? Were they not? So I interview kid, and then I interview parent separately. because you often get you can get insightful information from both, and then I interview them together. Parents and children rarely agree on symptoms. Parents can detail externalizing behaviors, but are often not unaware of how the child feels. Assessing using a variety of techniques, so play, drawing. I have a big whiteboard in my office, so I might have kids draw. I have all sorts of toys and sand, so I might play along with the kid as I'm interviewing them. So there's lots of techniques that we can use to interview kids. Getting a thorough developmental history, including the mother's pregnancy. Was she using substances? Was it a vaginal birth or a C-section? Did she have any complications, etc.? And then getting data from the school and how they're functioning in school, and a good thorough medical history. We always want to, when I'm thinking about assessing kids, I'm always ruling out, keeping things in the back of my mind, like, could this be explained by something else? We have a lot of assessment tools that we can use, standardized assessment tools. So I use a lot of the Vanderbilt for ADHD and the Connors. The Vanderbilt I send home, or I send to school and have teachers fill it out, and then I send to parents and parents fill it out, and it gives us good information about their ADHD symptoms. So here's a good list of various assessment tools. Treatment. So prevention and early intervention are the most effective. So early intervention, I would say, if we have not already, by the time they get to me, is important. School-age children, really incorporating family into the treatment, school into the treatment, and also the child, because it's their treatment. Work on improving school performance and social performance. Adolescents, helping them develop skills in conflict resolution, anger management, social skills. Addressing substance use with adolescents. And I actually ask, kids as young as 11 about substance use because I'm seeing more and more of it. Child and parent skill development is important. So a lot of our groups for kids are also parent groups. So kids are learning skills, and then parents are also learning skills and learning about what kid is learning about, so they can reinforce it. Individual, group, and family psychotherapy. I encourage all of my patients to be in therapy as well, no matter what their diagnosis is. Medication. We use medication is one of the ways that we treat ADHD. I tell a lot of folks that a lot of my folks with ADHD, so here's my disclaimer. Folks with ADHD have superpowers. Like I tell all of my people who have ADHD, they have superpowers. They're going to be the ones who, when there's a major crisis in the world and a catastrophic event, they're not going to be overwhelmed by everything that's going on because they're so used to having so much going on that they're going to be the ones who are going to be able to save the world. However, in our typical school system, the way it's set up, sitting 8 hours in school, well, you guys have been sitting for a while, and you're not even like 8 anymore. But kids without ADHD have a hard time sitting still for that long and paying attention for that long. And then when you add ADHD on top of it, it's like extra hard. So I like to talk about people with medications. It's really allowing you to thrive in this setting that is really not set up in a way that is great for allowing kids with ADHD to thrive. So we use a variety of different medications. We have our stimulant medications, and I kind of think of them as two, I should have restructured this a little, two different kind of classes of stimulants almost. We have our amphetamine products, so that's Adderall, and then we have several different products underneath our amphetamines, and then including the dextroamphetamines, and then we have our methylphenidate products, including dexomethylphenidate. So two kind of parents and then several different children underneath our classes of ADHD medications. We have extended release versions of things, immediate release versions of things. I talked with you all about stimulants last year when I did your psychopharm exam, or psychopharm lecture. We have non-stimulants as well, Strattera, which is actually an SNRI, so selective serotonin norepinephrine reuptake inhibitor. And then our alpha-2 agonists, which are blood pressure medications. And there are two that we use, and we use them in their extended release form to treat ADHD, clonidine ER and guanfacine ER. The nice thing about, so the Strattera and the alpha-2 agonists are medications that have to be taken on an ongoing basis every day. Can't take a break during the summer, can't take a break during the weekends. The nice thing about our stimulants is you can take stimulant holidays. You know, you don't have to take them during the summer if you don't want to. If you're on the weekend and don't need to focus and pay attention, you don't have to take them on those days. So, pros and cons to both. Nursing care. So, when you are providing nursing care to folks with ADHD, keeping them safe, keeping explanations and education short and clear. Again, they have a hard time with organizing things and with that working memory. So if we give them too much information, they can't hold on to it all. Simple instructions, one at a time. I tell parents this all the time. Sometimes parents will be like, go brush your teeth, put on your pajamas, grab your book, pack your bag, pack your lunch. And kid, gets to their pajamas and then they forgot what they, the rest of the stuff that they have to do. So keep instructions simple. Structure daily routines. Structure is really great for folks with ADHD and autism as well. Break tasks into small portions. Get the child's attention with eye contact, or I have, for my really impulsive kids who interrupt a lot, I tell them if they want to say something to mom and mom's in a conversation, to walk over and put their arm on mom, and then mom can put her arm back on kid, and which kind of reassures them, I'll get, I hear you, or I see you, I'll get back to you as soon as I'm done with this conversation. Conduct disorder, teaching using Green's model. We're going to talk about Green's model in a few slides. Limit setting, rules, structure, being non-judgmental, neutral and setting limits, so not getting really upset with them. That kind of escalates things. Working on coping skills and self-esteem, and modeling appropriate social skills. All right, got a question for you all. I'm going to have you just pull a 1, 2, or 3 for A, B, or C. Which of the following is the most appropriate response to a client who has thrown a table at the wall? A, it is unacceptable to throw furniture. Let's talk about what happened. B, what did you do that for? You damaged the wall. C, go to your room. You cannot put others in danger. All right. Rochester, can you give me some 1s, 2, or 3s, A, B's, or C's? Lovely. Okay, I'm seeing most 1s. You guys are so smart. Collaborative problem solving. So this is really an approach that Ross Green came up. I have on your slides, you're able to click those links and pull up his website to explore. I have a couple of videos as well in the slides coming up, but I think I will let you guys watch those on your own if you want to see them a little more. But really, to teaching collaborative problem solving it's important to establish an environment that's appropriate, that helps facilitate learning for the child. The goals of it are to teach. So we want to teach flexibility and adaptability. We want to teach folks to be able to tolerate frustration, how to problem solve, how to express empathy, and we also provide empathy to folks. Kids who demonstrate some of these more defiant behaviors can be really triggering for a lot of us. They can make us really angry and frustrated and mad. So as nurses, it's important that we remember what's behind the behavior, right? Every behavior has meaning. So when we are able to remember that every behavior has meaning, we are able then to express more empathy and kindness to these folks who are really suffering. And invite folks to kids to brainstorm solutions. They don't always have to be realistic. I like brainstorming to be all over the board whenever I'm brainstorming anything. So, Dr. Green, You guys can go to that website at some point if you'd like. Videos should be on your PowerPoint in Canvas if you feel so inclined to watch them. All right. Here's our last chunk, internalizing disorders. So again, these are things that, these are disorders that kids are really kind of suffering internally, and their behaviors aren't always these externalizing behaviors. So anxiety disorders, they're the most common psychiatric illness. More common in females than males. There's a strong coexistence of depression and anxiety disorders. So when I'm talking with my patients, I often talk about anxiety and depression together because they're really similar. Folks with anxiety disorders also come with a range of physical comorbidities. They can. Heart disease, again, with anxiety, our bodies are constantly in the fight or flight response, so putting us at higher risk for heart disease, high blood pressure, respiratory disease, migraines, those are all physical comorbidities, and GI problems as well. Again, long list of, or a list of various anxiety disorders: generalized anxiety disorder, panic, separation, mutism, phobias, social anxiety, and agoraphobia. There's a neurochemical component to anxiety. That's one piece of anxiety. Genetics play a role. Not quite as much as folks with ADHD, but still, folks who have parents, siblings with anxiety are at higher risk of having anxiety disorders. There are psychosocial theories of early anxiety and conflict, behavioral theories, and trauma. The neurotransmitters associated with anxiety, serotonin, so the thought is that we have too little serotonin, too little GABA, and if we have too much dopamine and too much norepinephrine, that can worsen anxiety. So from a medication standpoint, we're really targeting kind of primarily serotonin and sometimes GABA. GAD, generalized anxiety, fear and worry, it's uncontrollable. It must occur more days than not for 6 months. In kids, anxiety often looks like irritability or somatic symptoms. So when we think about kind of cranky or irritable kids, I'm thinking, like, are they feeling anxious? Are they depressed? Kind of what's behind that. And then somatic complaints. So in little kids a lot, I see kids complaining of stomach aches and headaches. Oh, I just don't want to go to school because my stomach hurts. That's often anxiety. Disturbed sleep. With anxiety, folks tend to have a harder time falling asleep. Concentration problems, fatigue, muscle tension. Mood disorders, we've got a list here. I'm only going to touch base on the major depressive disorder. Here's a list of some. So with major depressive disorder, it has to be present most of the day, every day for 2 weeks. And it's characterized by depressed mood, irritability, decreased interest in pleasure and activities, decreased or increased appetite, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feeling worthless, guilt, decreased concentration, recurrent thoughts of death. So suicidality is a symptom of depression. In kids and teens, when I'm assessing depression, I'm really looking at their isolation. Are they isolating from their friends? Are they isolating in their room? Are they irritable? And are they not wanting to spend time doing things that they've previously enjoyed? Emotional changes, again, irritability, feeling worthless, helpless, depressed. They're increased in suspicion or jealousy, if they're withdrawing, crying, sobbing, blaming themselves, blaming others, or lack of interest. So those are some emotional changes that happen with, and these happen in both depression and anxiety. Cognitive changes, they're forgetful, they're distracted, they have ruminative thinking, anticipatory worries, worrying about going to school, worrying about things that are going to happen in the future, intrusive memories, cognitive distortions, lack of attention to detail, homework they're not doing as well on, tests they're not doing as well on, focusing on the past, and reduced productivity, interest, creativity. So when we're assessing for depression and anxiety, again, we're doing really a full biopsychosocial assessment, looking at developmental level, parent-child interaction, separation, using a variety of, this slide looks very similar to the last one, actually probably identical. So all those things we're assessing too. Developmental level is really important in assessing anxiety, especially in little kids. There are, at certain developmental stages, it's normal for kids to have some anxiety from separating from their parent. So again, we're looking at when is that a normal developmental thing, when is it not. Assessment tools. Here are some assessment tools, screening tools that we use for depression and anxiety. Again, primary care is doing a much better job at screening for these things. Treatment, biological interventions, behavioral interventions. I'm just keeping an eye on time here. So improving sleep. Sleep is one of the most foundational things that I work on with folks. It's more important than we know, I think. Maintain an adequate diet. What we put into our body impacts how we feel and how we function. Serotonin, the building blocks of serotonin, amino acids found in protein. If kids do not have adequate protein in their diet, how can we expect that they're going to maintain adequate levels of serotonin, which is needed to help promote mood? Decreased sugar and carbohydrate cravings with increased stress. When our bodies are in fight or flight response, we crave energy because we need to run away from the lion that's chasing us. So we crave sugar and carbohydrates, things that are going to give us quick energy. Behavioral interventions, muscle relaxation and breathing. I want to touch base quick on deep breathing. Deep breathing is this word that we always are talking about. Like we're always telling people deep breathe, deep breathe, deep breathe. Does anybody know why deep breathing is helpful? So there's actually a physiological change that happens in our body when we deep breathe. I always tell my patients the why behind things. So with deep breathing, two important things. That your inhales through your nose and that your exhale through your mouth is twice as long as your inhale. And that is important because when our exhale through our mouth is twice as long, we trigger our vagus nerve. Our vagus nerve, so it kind of turns on our vagus nerve, and our vagus nerve turns on our parasympathetic nervous system response. When we are stressed, when we are anxious, we are in the fight or flight response. So we have to be intentional about turning on our rest and relaxation response. And deep breathing is the quickest, most effective way to turn on your parasympathetic nervous system response. If I had time, I would make you all do 5 deep breaths, but we don't have time. So today at some point, sit down and do 5 deep breaths. Cognitive behavioral therapy, another evidence-based treatment for depression and anxiety. Cognitive interventions, social interventions, medications, mostly SSRIs and SNRIs. We use a variety of other medications as well, but those are kind of the most common ones that we use. And treating anxiety and depression. So the research really shows that folks who have kind of more mild anxiety and depression, it can be well treated with lifestyle changes and therapy alone. No medications needed. When folks' depression and anxiety get to more moderate to severe type and start really impairing people's functioning, that's when we think about adding in medications along with lifestyle changes, along with psychotherapy. So I talk with patients about that too. CBT, cognitive behavioral therapy, is evidence-based for treating anxiety and depression and works on looking at our thoughts, feelings, and behaviors. It's kind of a little triangle. Nursing care, again, we want to help our patients identify feelings and learn appropriate ways to express those feelings. Identify and explore current coping strategies. Educate and introduce new coping strategies. monitor medications and side effects, and teaching about side effects of medications. And I know you all remember everything I told you in your psychoform lecture last year about that. Working on self-esteem, and then of course safety is really important. With coping strategies, I like to think of a toolbox, right? In a toolbox, there's lots of different tools for different purposes. So I talk to my patients about filling their toolboxes with different coping skills that they can pull out when they need to use them. So the more tools and the more different tools we can have in that toolbox, the more equipped we are to managing our stress. The mental health exam, you guys will probably be doing in your mental health clinicals, mental health status exams. These are things to consider: how they look, how they're interacting with you, their activity level, their speech, thought process, what they're thinking about, which is thought content, mood, affect, which is how they appear to be feeling. Suicidal ideation, of course, I think you touched on that in your lecture earlier today. Cognitive functioning and parent-child interaction. There are a couple case studies you guys can read on your own, if you so feel inclined. Questions? Rochester, questions? No, you all are like, we had an exam and another lecture, we're ready to go home. It's snowing, there's like 7 feet of snow out there. That's my email address. If any of you have any additional questions for me, or any interest in working in mental health and are curious, I love talking with folks about mental health nursing. Thank you for sticking with me. It's been great.
Thanks, Elena.
Good. I've already posted the YouTube video, so you guys already have that. If you want to watch it again, but I suggest you get something yummy to eat and treat yourselves well.
And maybe go build a snow person.
Yeah, do snowing.
Or go snowshoeing. Or sledding. Go sledding.
Oh, that'll raise the
Sorry.
It's so fun. Tubing, sledding, ice skating, just love yourself.